Welcome everyone. Welcome to the Virtual Physiatry Mentors. I'm Dr. Sheena Bhuva.
I'm Dr. Benecia Williams.
And together we are
Benecia. And that's the name.
Well, today we have something different. We have Dr. Marina Ma. She is actually double fellowship trained in pediatric rehab. We've had some great pediatric rehab physicians on our talk here, but never a palliative care fellowship trained physician. So this will be really exciting to kind of hear about why you went this route and what exactly you do. So this is obviously a very important part of rehab care. So thank you so much for joining us.
Yes.
Thank you for having me.
We're excited. Yes. So Marina, thank you again for joining us. And tell us a little bit more about yourself. Tell us where you're from, where you did your training, and we'll go from there.
Yeah, so I was actually born and raised in Jakarta, Indonesia. For people who don't know where Indonesia is, sometimes you've heard of Bali, the island of the gods, surfer's paradise. Jakarta is the capital city for Indonesia, and Bali is one of the islands in Indonesia. And I went to Singapore to complete my high school, and then I decided to come to the United States to do my undergrad. But I think once I was in undergrad, I came with the intention of doing med school. Once I went to Berkeley, that's where I went for undergrad. It was like such a big school. I was like, oh, my gosh, there's so much opportunities. So I decided, you know what, maybe I should explore other things. So I went, I decided not to go to med school. I went back to Indonesia, explored other things, and then I decided I miss science. So I ended up doing med school there because I did the cost benefit analysis. It was actually a lot cheaper.
Smart lady.
It was $15,000 for the whole of med school.
Oh wow,
that's amazing.
Yes. But then once as I was completing med school, I was like, so where do I go next? And I decided to come back to the United States for residency. So for intern year, I was at Jacobi Medical Center in the Bronx. Mm-hmm. And then for residency, I was at Georgetown NRH. And for the first fellowship, I was at Cincinnati Children's. That's for the Pediatric Rehab Fellowship. And then for my second fellowship, I went to Baylor, Texas Children's, for the Pediatric Palliative Care. So I went west, east, Midwest, and made my way down to south.
Awesome. Very cool. I actually have two UC Berkeley alums here right now, my brother and sister-in-law. Go there. Yep. Small world.
So Dr. Ma, you mentioned that you are from Indonesia and went to school there, and we actually have a pretty large following on our Instagram of PM&R residents in Indonesia. So how did you actually learn about PM&R while you were doing medical school there? Tell us a little bit about what got you interested in PM&R.
Yeah, so actually when I did med school there, PM&R isn't a very well-known specialty. I only knew of one other person, and she was much senior than I was then. However, I think it's more of the principles of PM&R that attracted me to it. And I think that was the missing piece. And that's why I think one of the big reasons why I didn't end up doing it there. One of the things I discovered was I had a lot of patients who suffered from stroke, and then they ended up just being bedbound because they don't have a rehabilitation pathway. I saw a lot of amputees, and again, they're usually wheelchair bound because there is no physical therapist, nobody making their prosthesis. And to be honest, I didn't see a lot of people with disabilities out in the community, but they exist. Right. I think it's just because we are not enabling them to participate in the community. So I started looking up, and then I was like, oh, there's actually a specialty just for that. And then it's called physical medicine and rehab. And that's what made me come to the United States for the residency. Yeah.
Very insightful of you to think about that. No, very cool. Like Sheena said earlier, we've had really cool pediatric rehab doctors on, probably more than any other niche in PM&R, which I think is really cool. And you guys work with such a wonderful patient population. Explain to the audience exactly what palliative care is, because I don't think people really get exposure to it. I know I rotated in palliative care as a medical student, but we didn't get exposure as residents. And but I work with them every day at the hospital when I see the stroke patients. So explain to the audience exactly what palliative care is.
I will try.
Yes, and what drew you to it?
So palliative care, palliative comes from the word palliate, so it's to relieve suffering without actually giving the cure. And so it's about relieving suffering, and it's something that can be offered at any point of the disease, and it's offered to somebody with a serious illness. What I meant by any point of the disease would be at the time of diagnosis, in the middle of treatment, and also end of life. So sometimes some people say, isn't palliative care the same as hospice? They're actually very different. Well, they're not very different, but it's different. Hospice is a subset of palliative care. When we talked about end of life, that's what hospice refers to. But palliative care in general is at any point of the disease. And somebody might ask, so what do you do for the patient or for the family even? And we provide an extra layer of support. And what I say to families, or how I explain what our specialty does, is we provide an extra layer of support to the patient and to the family. And it can be in the form of many different things. It's basically based on your needs. What we do is we get to know you, we get to know your family, and that's how we can assess what your needs are. Some of the things that we offer would be, one is symptom management. It can be relief of nausea, relief of pain. What else do we do? Or delirium. So we really look at the symptom burden and try to figure out what ways we can do medications or even non-pharmacological things that we have in our toolbox. And second is we provide support to the family, because being in the hospital is difficult, especially when you have such a serious diagnosis. And we have a social worker on our team. We usually also have a chaplain on our team, and we try to look at the big picture, look at the family, and see what are the needs that the family has. And the last one is, I think, in the form of communication. We try to make sure that the patient and the family is getting a unified message, because sometimes you have many different specialties and they all look at their own specialty. And so one might look just at the GI tract, the other person might look just at the respiratory component, but then we're missing the bigger picture. So we try to kind of corral everybody together and say, this is the plan. And also sometimes I think families are faced with decisions that they're faced with multiple decisions, and they're not all right or wrong. It truly depends on what your values are. And I think it can be very difficult for parents to sometimes choose, yes, I want to say, get the tracheostomy, but then they don't understand the repercussions after that. So we help families kind of talk about what's important in their life, what are their goals for their child, and then tailor our treatment recommendation according to those goals and those values.
Great, such a need for that.
Such a need, and I try to explain to patients all the time, because I consult palliative all the time. I'm like, it's not the same thing as hospice. I'm like, you just have, like you said, another level of support. You have more resources, and it's just you'll be happy that they're on your team, because there's a lot of resources out there that, like, I think PM&R knows a lot of resources, but there's even more resources available with palliative care. So I really commend you guys for what you do. It's a great skill to have.
And Dr. Martin, so you strictly work with the pediatric population then when it comes to palliative care? Yeah.
I do. I'm based at Texas Children's.
And so what are some of the diagnoses that these kids have?
I'm in the neuromuscular clinic, so a lot of patients with Duchenne, SMAs, and other muscular dystrophies, spina bifida. I think a lot of kids with cerebral palsy, the GMFCS levels 4, 5, the one who are affected in all 4 limbs, and then they're also cognitively affected, and they have trouble eating, swallowing basically, and also breathing wise. A lot of kids with congenital heart, cystic fibrosis, quite a number of diagnoses, and cancer, kids with cancer.
Are you strictly outpatient, or do you do inpatient, outpatient?
Inpatient. What I do, because I have a dual appointment, I do 80-20, so 80 physical medicine and rehab, and then 20 palliative care. That 20% is solely focused on inpatient. But my other palliative care colleagues, they do both inpatient and outpatient.
So Benecia alluded to this, like we in residency, we didn't have too much exposure to palliative care. We both did rotations as medical students, but for those PM&R residents who are interested, what advice would you give to kind of seek out those opportunities during residency to learn more? And then if they are interested in a fellowship, you know, how can they become more, that's what I'm looking for, more competitive, you know, for a fellowship?
For sure. I think get as many exposure and experience with a palliative care team as much as possible. Do an elective with a palliative care team. Look, we have an equivalent. We have our PM&R equivalent. It's called AAHPM, and we also have a yearly conference. Go attend those. They have, I think, it wouldn't surprise me if they have sessions just for the medical students or residents. Don't quote me on that though, but it would surprise me if we don't. And there are also plenty of websites, such as CAPC. So it's Center to Advance Palliative Care. And they even have courses tailored for you, and you can enroll and then do like an actual syllabus and curriculum. And there's for PM&R physicians who are interested in geriatrics, there's also GeriPal, GERIPAL.com. There's Pallimed.com. And to be honest, one of my most helpful resource is actually just listening to parents talk about their children and talk about how they end up making the decisions that they did and what was their thought process. One of them is courageousparentsnetwork.com, and it's just amazing how they're willing to share, and how much I was just truly humbled by all the thought process behind their decisions, and then how much they value their child's lives.
What drew you to palliative care? Was it during your pediatric fellowship, or did you kind of know that you wanted to go into it before then?
Yeah, I think it was as I was doing my rehab residency. I think mid-part, I just felt that there is this sort of unfinished business in a way. It's like sometimes when you have your patients who's sick and rehab alone isn't enough, and they're in their next phase of their journey, I feel that I want to be a part of that. I want to follow them to the next part. And I think, where was I going with this? But it was more of, and it's not similar to rehab. Palliative care is also about team, being part of a team. Just like rehab, you have your PT, OT, speech, and care managers. In palliative care, we have our chaplains, social workers, grief and bereavement specialists. And sometimes those are the people that came in clutch during a patient encounter. the social workers are the one that have the solutions for the family or the patients. And we're the one who's just like, okay, time to keep my mouth shut and just let them do their magic.
They're magicians. I say that all the time. I'm like, case management, I'm like, you guys have the hardest job in the hospital because they will pull some stuff out of nowhere. I'm like, thank you so much. They do come in clutch.
Yeah. And sorry, one thing that I forgot, what I learned the most from my palliative care fellowship was the ability to communicate better with my patients and my patients' families, and also to not be afraid to address the elephant in the room. If something isn't going well, or if we don't think they should go for treatment X, then I think I'm more courageous in kind of like just addressing it head on. Of course, knowing where the patient and the families are at that point. But yes.
I remember in residency, people asking about stem cells when we're on our pediatric rotation, or like hyperbaric treatments, and kind of just coming up with all these and just having to be straight up and be like, there's not as much research out there supporting some of this stuff. So it can be tough, I'm sure.
I think in being in pediatric, I mean, being just in rehab, we would say all the time that, you know, by the time patients kind of got to rehab, they finally have time to process stuff that they didn't hear on the acute care. Like, how many times have we had to tell oncology patients like what their diagnosis was and prognosis, like all the time, right? When we're like, I know they taught someone, I'm like, no one told you this, but they just, it's such a disconnect because so much is happening and they just can't process. And then you just have to sometimes, and you feel like you're the bad guy, but I think you get more comfortable, like you said, like telling people, hey, this is what it is, this is where we're at, but how can we move forward and make your life better for what's left, or what, you know, how much time you have left.
Yeah.
Exactly.
Well, guys, if you have any questions, please type them out in the comments. Got some of the viewers here.
Someone says, Dr. Ma, you are so inspiring.
Thank you.
Ziki. Oh, that's so sweet. Yeah, if you guys have any questions, please type them out. I have a question. How was it matching into PM&R coming from outside of the country? Was it a difficult process? We get asked this question all the time. So I was like, oh, we have to talk to her about this. What was your experience?
It was difficult. I think I was lucky. A lot of things lined up for me. And I think it's a lot about taking opportunities when they presented itself, and also giving people the space or even the opportunity to offer you that possibility. Like when I first came, when I first returned to the United States from Indonesia, I was in Miami doing my board exams, and I was also volunteering at Jackson Hospital. And then it was actually the unit clerk or the unit admin who introduced me to one of the attendings, who then wrote a letter of recommendation for me. And I'm pretty sure somehow, I hope, I'm not sure, but gave me one of the interviews. And I think it just got the ball rolling from then on, you know? I mean, having good board scores help, but there are also the extras that I think just also has to line up for you sometimes. But you also have to be willing to take on those opportunities, and you have to be willing to let people in to help you.
Good advice.
Yeah. And I did interview at a lot of places.
Did you?
Quite expensive.
You just need one. You just need one to rank you.
No, absolutely. Any questions out there? Oh, here we go.
All right, so Dr. Reski Amalia Nurshal, so she's from Indonesia. She's a physiatrist there, and she's asking, is it possible if physiatrists from Indonesia can do observerships or fellowships in the US?
My understanding is you have to do a residency before you can do a fellowship. I don't think we offer if I'm not mistaken, radiology offers like possibility of doing fellowship, but not for PM&R. Observerships, I think Texas Children's, actually, we just had our first international observer from Korea, South Korea. Unfortunately, the end of his observership happened during the pandemic, so he got to return home, but it is a possibility. And there are programs out there that allow for international observerships.
Oh, that's awesome.
Yeah, I think, observerships are probably much more doable than, because most of the fellowships they require you to have graduated from an ACGME residency, like you're saying. So,
how has COVID affected you guys?
For rehab or palliative care?
Both.
Both.
yeah, have you had kids that have had COVID and you've needed to talk to parents with decisions? Just
Yeah. I specifically have not had that conversation. I know a lot of my colleagues have. I did see one kid who was very deconditioned after getting COVID. So, it affects kids sometimes just as hard. And I think it took him 2-3 weeks to even walk without using oxygen, like supplemental oxygen.
Yeah.
And he went home. We prescribed oxygen as needed for him to go home at discharge. And I think it has changed the way we do injections, procedures, mask, goggles. Definitely, I think what's affected most is therapy services, because prior, parents would have therapists come, PT, OT, speech, but now they're very, very worried about exposing their children, especially those are at very high risk. So you see more contractures, and it's just more difficult in general. As for palliative care, one of the way we support or we give comfort is by touch sometimes, and COVID has robbed us of that. Sometimes just a touch on your hand, it means a lot, or just on your back, to be able to show that you care. And I think visitor restriction is very, very difficult on our parents, especially when the kid is in the ICU. They're very unstable, and you can only have one parent at bedside, and it's excruciating.
It's heartbreaking. It is. I can only empathize. It is horrible to think about. Yeah, I feel so bad for these patients, especially like when we went on lockdown, where we can have any visitors at all. Like, oh, it's just so sad.
I think with like pediatric population, they had always let at least one patient or one parent in the room. Yeah.
I think it'd be difficult otherwise. They'd be crying for mom or dad.
Yeah, I can only imagine. And then someone has to be the decision maker too, right?
Yes. And then you'll have parents that said, I can't even go to the bathroom because I'm afraid of missing rounds, or I'm afraid of missing something big on my child. And you're like, I can stand here for 5 minutes. Why don't you go to the bathroom? Or why don't you just go down, get coffee, get a breath of fresh air?
Right.
Yeah.
Absolutely.
A lot of self-care. Yes. Forget about as parents sometimes. Any other questions out there?
If not, we'll ask your famous question. Dr. Ma, if you were not a pediatric palliative care physical medicine rehab doctor, that's a lot of P's, right? What would you be?
Oh, that is such a hard question. I feel so lucky to have found what I absolutely love doing. It's really hard to imagine me doing something else. But if I have to really, 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 really choose, I have a lot of things. Okay. I am in awe of our social workers. So I would do social work, definitely. Being the person to hand out, hey, I have gas money, I can housing assistance, or I mean, that's not all they do, but being able to be able to do that is really awesome. Pilates instructor, or like I'm getting into hiking again, so I've been doing a lot of shopping at REI, being one of those workers at REI who knows, like, oh, I know this gear for this, I know that, I've hiked this, I've gone climbing there, and I'm like, oh yeah, your life is so cool, and I'm in the hospital.
I know. Sheena and I like to hike too, so Sheena's a really avid.
I hear you on the REI. It's a fun store. It would be fun to work in for sure. So.
Sheena once took me on 3 hikes in one day, and we did 3, right? In Sedona?
Yep. Benecia came and visited me when I was in fellowship. Yep.
We did 3.
They were good. They were good.
They were great. It was good. That last one was the hardest, but it was amazing. Fun time.
All right. Well, thank you so much for joining us. I'm sure, we have people that view the video now, and then a lot of people that view it later. So if anyone has any questions and would like to reach out to you, what would be the best way that they can get a hold of you?
They can reach out to me via my email. So that would be mymarina MY Marina, MARINA @cal.berkeley.edu. So mymarina@cal.berkeley.edu. Message me on Facebook. Pretty easy. And my work email, if you want something more formal, that is mxma2@texaschildrens.org. And if need be, you can always get in touch with me via my cell. And
you don't have to give it out. And we usually what happens if people, they'll watch this and write it down, or they'll contact us and we'll you don't have to give it out.
I would be more than happy to answer any questions, because I know that, especially for the international medical grad, this journey is not easy, and you will have many ups and downs, and there will be times where you doubt yourself, but at the end of the day, it is possible. And I think somebody lent a hand to me, and I want to be able to pass it on too.
Oh, well, we think you're awesome. We really appreciate you taking the time out and joining us. So yeah, everyone who's watching already knows how to kind of follow us. We're at the.physiatry. I mess this up every single time. I do. I literally do. I'm like, that's not right. It's at the.virtual.physiatry.mentors on Instagram and Facebook. Both Sheena and I are on Twitter, so follow us on there. We will have this uploaded on Instagram TV and YouTube by tomorrow, and then we'll send it out to you as well. So thank you so much for joining us. What do we have? We're
taking a break. Yep. So everyone have a safe and fun Thanksgiving. So we're taking next Sunday off, but I think we'll be back Sunday after. We'll have to look at our schedule. And we've been in MIA on our Instagram posts. We've just been so busy with work right now. The end of the year gets crazy, but we are going to try our hardest to get very active this week. So, all right, guys, thank you so much for joining us.